Hi guys! This week I'll be doing my clinical presentation over asthma. As we talked about in last week's discussion board, I like to be a little extra with my presentations, so I sprinkled some cute little slides in here like this. This one is a quote and says, "You will never know just how much you value your breath until you can't breathe," by someone famous. And that just resonated with me personally and with this topic too, of course. Here is my table of contents that displays all of the key points we will be discussing throughout this PowerPoint presentation. And for this first section, we will be discussing the pathophysiology of asthma. Fun fact, 28 million people in the United States have asthma. It is also the leading cause of chronic disease in children. Of the 28 million people that we previously mentioned, 4.9 million of these individuals are children who are under the age of 18 and currently living with asthma. Asthma's pathophysiology is complex, but comes down to three main characteristics. These are airway inflammation, intermittent airflow obstruction or bronchoconstriction, and bronchial hyperresponsiveness. But when you're trying to set this apart from other diseases that share similar characteristics, one important thing to remember with asthma is that it is considered to be a reversible obstructive lung disease versus an irreversible one, such as COPD. Asthma is a syndrome with multiple underlying mechanisms. It generally involves the same cells that play a predominant role in the allergic response in the nasal passages and in the skin, which supports the belief that the consequences of mast cell activation, mediated by a variety of different cells, as shown in this slide, cytokines, and other mediators, are key to the development of clinical asthma, with eosinophils being the most characteristic cell that accumulates in both asthma and allergic inflammation. Although, side note, it's important to know that some patients with asthma do not have eosinophilic infiltration of the airways. So, overall, these IgE mast cell mediated responses in the body lead to the bronchoconstriction, inflammation, and bronchial hyperresponsiveness, as we mentioned in the last slide. Then, there are modulatory factors that research suggests may play a role in the development of asthma. These include genetic factors, environmental factors, such as exposure to air pollution or other allergens in the environment, and infectious agents, such as both bacterial and viral respiratory tract infections, which have been associated with an increased risk for developing asthma. In this next section, we'll be discussing the signs and symptoms that you would typically see in an asthmatic patient who may present to you in clinic. There are three main or classic signs and symptoms in asthma. These are intermittent dyspnea, a cough, and wheezing. Interestingly, asthma is more common in adult females than it is in adult males, while in childhood, it is more common in males than it is in females. Some studies suggest this trend reverses in adulthood because of the effects of testosterone on the cells of the lungs. Testosterone, a predominantly male sex hormone, has been found to decrease the swelling of the airways in asthma. So, as men start to get older and accrue more testosterone in their bodies, they are more likely to outgrow their childhood asthma, whereas with women, this is not always the case. And then we see this shift in trends. Next, we'll be discussing how to diagnose a patient with asthma. When diagnosing a patient with asthma, you could diagnose them based on their medical history alone. A history of intermittent symptoms typical of asthma, plus findings that are present on physical exam, such as its characteristic musical wheezing, strongly points to a diagnosis of asthma. So you could take this route in diagnosing and then going on to treat it. Or you could confirm the diagnosis based on two key additional elements. One is the demonstration of variable expiratory airflow limitation, preferably by spirometry, or PFTs, and two is the exclusion of an alternative diagnosis, such as COPD, for example. You can achieve these two things by spirometry and bronchoprovocation. Spirometry is the primary method of confirmation of variable airflow limitation, which may be demonstrated by testing before and after the administration of a bronchodilator, testing from one office visit to the next, before and after exercise, or before and after the methacholine bronchoprovocation challenge. Bronchoprovocation detects the presence of airway hyperresponsiveness, another key feature seen in asthma, whereas with spirometry, it looked at variable airflow limitation. This one looks at airway responsiveness. So with the bronchoprovocation challenge, it's especially helpful when attempting to exclude an asthma diagnosis. After diagnosing someone with asthma, you can categorize the severity of their asthma into one of these three categories: mild, moderate, and severe. Then, from there, we can categorize asthma into one of these four levels: mild intermittent, mild persistent, moderate persistent, and severe persistent. These are according to the guidelines established by the National Institute of Health in both the National Asthma Education and Prevention Program, or the NAEPP, and the Global Initiative for Asthma, or GINA, which both recommend starting with a determination of asthma severity to help guide initial therapy. And here's another fun quote I thought sounded fitting for my topic. It says, "It ain't easy being wheezy." Next, we'll go over treatment options for people living with asthma. As I said before, both the NAEPP and the GINA recommend starting with a determination of asthma severity to help guide initial therapy. In order to do this, you must determine several things: the frequency in days per week of daytime symptoms, the frequency of nocturnal awakenings in a month, the frequency of quick-acting relief medication use, how many days per week they're having to use it, how much their symptoms interfere with normal activities of daily living, so like work and school, evidence of airway obstruction via their FEV1 scores, and number of exacerbations in a year. In addition to these, it may also be helpful to ask what specific symptoms they've been experiencing, if they've needed any unscheduled care for their asthma, like if they've needed to seek out care at an urgent care or hospital setting, have they been able to participate in recreational activities as desired, and if they are measuring their peak flow at home, which we'll talk about a little bit more a little bit later, has it been reading lower than their personal best? So originally, when I learned about asthma treatments, I was shown this stepwise approach. This is the National Asthma Education and Prevention Program stepwise approach. But recent guidelines now state that an as-needed SEBA therapy alone is not recommended, even in mild cases of asthma, because of severe exacerbations and mortality risks. Instead now, they recommend the use of an as-needed low-dose inhaled corticosteroid formoterol combination in all adolescents and adults with mild asthma, so they've moved to this new 5-step approach for asthma treatment. These are the newest guidelines from the 2022 Global Initiative for Asthma, GINA, update. One easy trick I recently learned to help you remember what patient belongs in which stepwise category is by looking at the amount of nocturnal awakenings that they've been having. So in step 1 and 2, nocturnal awakenings are occurring 2 times or less per month. And then in step 1 and 2, there are nocturnal awakenings that occur two times or less per month. In step 3, they occur 3 to 4 times in a month, or approximately once a week. In step 4, nocturnal awakenings occur 1 or more times per week, or 4 or more times per month. And in step 5, nocturnal awakenings are occurring nightly, or most nights per week. When titrating up therapy, it's also important to remember to address any modifiable environmental risk factors and other comorbidities alongside adherence to the patient's regimen and appropriate inhaler technique. I won't go into the specifics of each class of asthma medication, but wanted to include this slide so you guys could read it on your own time if you'd like. But basically, the common categories of pharmacological treatments for asthma include beta-2 agonists, such as short-acting beta-2 agonists, otherwise known as SEBAs, leukotriene antagonists or modifiers, such as montelukast, long-acting bronchodilators, such as long-acting beta-2 agonists, also known as LABAs, antimuscarinics, i.e. LAMAs, oral and inhaled corticosteroids, anticholinergics, biologic monoclonal antibodies, and last but not least, subcutaneous immunotherapy, SCIT, or allergy shots. I couldn't fit those last two things on the last slide, so I kind of included both of those things here. So with biologic medicines, such as biologic monoclonal antibodies like benralizumab, these are helpful for difficult to control asthma symptoms, and allergy shots, also known as subcutaneous immunotherapy, may help to turn down the body's natural response to allergens. This slide kind of goes into further detail on these last two processes. Then, these are the three types of therapies often described in the treatment of asthma that use different combinations of asthma medications that we've previously discussed to treat asthma. Of note, AIR has been promoted by national and international guidelines based on its decreased exacerbation rates across many differing levels of asthma severity, and is particularly helpful for patients with seasonal or otherwise variable symptoms, as well as in those with frequent exacerbations. Here is a breakdown on the cost of asthma in a year, on average across the United States. It is said that medical costs for people with asthma are estimated to be $3,266 higher per year compared to medical costs for those without asthma. From 2008 to 2013, the annual economic cost of asthma was more than $81.9 billion. This includes medical costs and loss of work and school days altogether. Lastly, we will be discussing patient education in relation to the treatment of patients living with asthma. First and foremost, it is important to talk about controlling asthma triggers. Directed questions can help to identify specific triggers such as allergens like pollen, pet hair, mold, cockroaches, etc. Then, identifying any irritants such as fumes, cigarette smoke exposure, and things of that sort. And then respiratory viruses and physiological triggers such as stress, hormones, and exercise may all be playing a role in asthma symptoms. Non-pharmacological approaches to asthma control include the avoidance of these asthma triggers, weight loss, especially in patients with obesity, smoking cessation in those who smoke, improving medication adherence, and developing an asthma action plan, which we will go into more depth about here in a few slides. Additionally, providers should strongly encourage age-appropriate vaccinations against influenza, pneumococcus, pertussis, severe acute respiratory syndrome coronavirus 2, and the respiratory syncytial virus, or RSV, in all patients with asthma. Of note, adults ages 19 to 64 with asthma should receive an additional pneumococcal vaccine, and all children ages 6 to 18 with moderate to severe asthma may likewise benefit from an additional dose, depending on their prior vaccination status. Then these are all educational topics to review with patients who present to you with asthma. These include inhaler use, such as ensuring patients are utilizing the correct inhaler technique to provide themselves with their inhaled medications, pre-medicating to prevent the onset of symptoms in some patients, how to store your inhaler, and ensuring their adherence to their medication regimen. Then you could educate patients on how to correctly use a peak flow meter. The management of asthma highly relies on a patient's ability to monitor their asthma symptoms regularly. Such measures may include the measurement of lung function with a peak flow meter or spirometry. Peak flow meters measure your peak expiratory flow rate, or PEFR, a number that correlates with how open the lungs' airways are. As asthma worsens and the airways begin to narrow, the PEFR decreases. Teaching patients to monitor their PEF at home can help patients and providers determine the most appropriate asthma treatment plan. Then, it's also important to educate your patients on the symptoms associated with an acute exacerbation of asthma. These might include an increase in the intensity or frequency of symptoms such as dyspnea or shortness of breath, nocturnal awakenings, wheezing, cough, and chest tightness, all of which interferes with one's normal activities of daily living. If the patient checks their lung function via peak flow or home spirometry, it may be significantly reduced. Asthma attacks can come on over a few days or even occur suddenly. Some people have mild asthma attacks that can be easily treated at home, while others have severe attacks that require emergency medical services and even hospitalization. It's important then to review asthma action plans with patients to ensure they know exactly what medications to take and at what dose and when they should call the office or seek out emergency help. Speaking of acute exacerbations, you should educate patients again on the asthma action plans and help them to develop an asthma action plan, which includes the principles of self-management for early recognition and treatment of future attacks and recurrent symptoms. A personalized asthma action plan is a written document that provides instructions for the patient to follow at home. In this slide and in the last slide that I showed, I included these pictures which make up what an asthma action plan looks like. Many experts believe that written asthma action plans are useful to help engage patients in their disease management, help clarify their regimen for them, help them to identify declines in asthma control, and guide treatment adjustments in response to patient readings and symptoms. And then finally, it is very important to follow up with your asthma patients. Effective asthma management requires a proactive, preventive approach, similar to the treatment of hypertension or diabetes. Routine follow-up visits for patients with active asthma symptoms are recommended, at a frequency of every 1 to 6 months, depending upon the severity of asthma and adequacy of control. Follow-up visits should be used to assess asthma control, lung function, exacerbations, inhaler technique, adherence, medication adverse effects, quality of life, and patient satisfaction with care. And so finally, that's it for my presentation over asthma. Here are my references that I used to create my PowerPoint presentation. I hope you guys all enjoyed my presentation. And of course, if you have any questions or want further clarification on any of the topics that we discussed in today's presentation, feel free to reach out to me via email or text message at the contact information I provided here. And I hope you guys have a great rest of your week this week. Thanks for watching. Bye.